I'm Dr. Heidi Klessig. I'm a retired anesthesiologist and specialist in pain management, and I'm the author of The Brain Death Fallacy. One night when I came in for night call as an anesthesiology resident back in the 1980s, I reported for duty to the operating room desk and was told that I was to go up to ICU and bring a brain-dead man down to the operating room for organ procurement. At the time, I know I'd heard something about brain death in my medical school program, but I didn't have all the facts right at hand. So I asked the anesthesiologist who was running the operating room schedule, brain death, huh? Is there anything different about this that I need to know? Well, he just laughed and he rolled his eyes and he said, just be sure, someone has actually declared him brain dead. You know how eager the transplant team can be. Well, that wasn't reassuring to me at all, but I went up to ICU and I found my patient. He was a young man, about my own age at the time. He had been in a motorcycle accident and sustained a severe head injury, and yes, the neurologist had declared him to be brain dead. But when I went to look at my patient, he didn't look dead. He was warm, he was pink, he had excellent blood pressure and heart rate and oxygen saturation. He was on very little as far as drips or infusions. In fact, he looked like every other ICU patient I'd cared for and better than most. So I took these facts down to the operating room and I found the supervising anesthesiologist who was going to be instructing me for the case, and I presented the case to him and he said, well, what's your anesthetic plan of care? So I said, and this shows how brainwashed I was at the time, I actually told him, I think I'll give the man a paralyzing agent so he doesn't move during the surgery and interrupt what the surgeons are trying to do. And I think I'll give him some fentanyl as a potent painkiller to blunt any heart rate or blood pressure responses that might damage the organs. So then he looked at me and he said, are you going to give a drug to block consciousness? Well, I was stunned. Why would I do that? I asked him. Isn't he dead? And I'll never forget the long, slow look he gave me over his operating room mask. And he said, why don't you give him a consciousness-blocking drug just in case? And he walked away. Well, to my regret, I did what I was told. I took the young man and I brought him to the operating room. I gave him the anesthetic drugs that we had planned, and I'm here to tell you he reacted to the incisions, to the bone saw, to the removal of his organs, just like anyone else, requiring the same types and amounts of anesthesia. You know, when I told this story to a pathologist friend later, she told me that when she does an autopsy in the morgue, she doesn't need to give any of these drugs. So this experience made me wonder, when is someone dead? You know, for thousands of years, you didn't need a doctor to tell you when someone was dead. Death was declared at home, on the farm, on the battlefield, by the absence of heart rate and breathing and the passage of time. People associated death with the departure of the indwelling soul or spirit or life force, but because we have no way of seeing when an immaterial life force departs, we use these physical signs. The other thing that's important to note is that if you could still be resuscitated, you are never dead. No one comes back from the dead, which would be resurrection, without divine intervention. But in 1968, 13 men at Harvard Medical School wrote a landmark paper in the Journal of the American Medical Association called A Definition of Irreversible Coma. These 13 men at Harvard thought that we could redefine certain people in a coma as being dead already. Now, their paper had no scientific references. They said, our primary purpose is to define irreversible coma as a new criterion for death. But does changing a definition change the reality? The only rationale they gave was one of utility. They said redefining certain comatose people to be dead already would free up ICU beds, and it would remove the controversy over taking their organs for transplantation into somebody else. Now, Their redefinition certainly was of great utility in one sense because it allowed doctors to skirt what is known as the dead donor rule. The dead donor rule says that people must neither be alive when their organs are removed, nor may they be killed by the process of organ removal. So redefining what it means to be dead allowed organ procurement to skirt the dead donor rule by simply declaring by the stroke of a pen that these people were somehow dead already. The only multi-center prospective study of the idea of brain death took place back in the early 1970s. It was the National Institute of Neurologic Disease and Stroke Collaborative Study. They took 226 brains from people who had been declared brain dead, and interestingly, the standards for brain death back in the early 70s were stricter than those that we use today. Of these 226 brains, 10 on pathological examination were grossly normal, and only 40%, less than half, showed widespread brain destruction. The authors of the study said that it was not possible to verify that a diagnosis made before cardiac arrest, the traditional means of determining death, would invariably correlate with a diffusely destroyed brain. Dr. Gaetano Molinari, one of the leading investigators of the study, wrote, "Does a fatal prognosis permit the physician to pronounce death?" He went on to say, "It is highly doubtful whether such glib euphemisms as, 'he's practically dead,' 'he can't survive,' 'he has no chance of recovery anyway,' will ever be acceptable legally or morally as a pronouncement that death has occurred." But as we all know, that's exactly what happened. In 1980, a presidential commission was convened, and they wrote a paper called Defining Death. The information that the Defining Death authors received back in 1980 was that people with a brain injury would very quickly go on to have cardiac arrest within days to at most a few weeks. So they decided in favor of the brain death concept because back in those days, they thought that once the brain stopped working, biological death would very quickly occur. Did you hear what I just said? Would very quickly occur. Their whole argument was based on a prognosis of death, not a diagnosis. Just as Dr. Molinari had said during the NIN-CDS study, brain death is a prognosis of possible death. It's not a diagnosis. And in fact, all of the authors of Defining Death did not agree with the conclusions. Harvard professor of philosophy Daniel Wickler, who wrote Defining Death's third chapter, Understanding the Meaning of Death, told reporter Rachel Aviv of The New Yorker years later, "I was put in a tight spot, and I fudged. I knew that there was an air of bad faith about it. I made it seem like there are a lot of profound unknowns and went in a direction of fuzziness so that no one could say, 'Hey, your philosopher says this is nonsense.' That's what I thought, but you'd never know it from what I wrote." Well, despite Dr. Wickler's doubts, the Uniform Law Commission codified Defining Death's ideas about brain death into U.S. law in 1981 as the Uniform Determination of Death Act. And even today, the Uniform Determination of Death Act, or UDDA, is used by most states. There are two ways to be declared dead in the United States under the UDDA. The first is the irreversible cessation of circulatory and respiratory function, the traditional means of determining death. The second is the brain death idea, and that one says the irreversible cessation of all functions of the entire brain, including the brainstem, is dead. But are brain dead patients dead? The evidence shows that they are not. Dr. Alan Schumann, a pediatric neurologist from UCLA Medical School, in 1998 published 175 cases of brain dead people who lived. Now, all of these people had been considered brain dead enough to have been offered the opportunity to become organ donors, but for one reason or another, they were kept alive. In fact, one of these patients lived for more than 20 years at home with his mother. These people are not dead. These cases show that brain death is, again, a prognosis of possible death and not death itself. Because of Dr. Schumann's work, another presidential council was convened. They noted that Dr. Schumann's work left two options. Either we have to abandon the neurological criteria for determining death, or we have to determine a new rationale to explain why neurological criteria should equal death. Well, we know which one they chose. They chose to define a new rationale based on a questionable philosophy rather than on biology. They coined a new term, total brain failure, and they said an organism is no longer alive when it ceases to perform the fundamental vital work of a living organism, the work of self-preservation achieved through the organism's need-driven commerce with the surrounding world. This is an ableist definition, and in fact, the 2008 President's Council failed to accurately represent scientific facts. Total brain failure is inaccurate because people with a clinical diagnosis of brain death still have certain brain functions. 20% of those tested, and again, not many are tested because an EEG is no longer a requirement for a brain death diagnosis, but 20% who are tested still have electrical activity on EEG. More than 50% have a functioning hypothalamus, an important part of the brain that's responsible for temperature control, salt and water balance, and therefore blood pressure, sex drive, awareness, and pain. And brain-dead people still have metabolism, wound healing, the ability to fight off infections, and as an anesthesiologist, I can tell you from firsthand experience, they still have the stress response to the incision to procure organs as any other patient. The chairman of the 2008 Presidential Council, Dr. Edmund Pellegrino, wrote a dissenting opinion. He wrote, "The only indisputable signs of death are those we have known since antiquity. Loss of sentience, heartbeat, breathing, mottling and coldness of skin, muscular rigidity, and eventual putrefaction as a result of generalized breakdown of the body's cells. I have chosen to give priority to the welfare of the patient before he or she becomes a donor on grounds that harm must not be done, even if good comes from it. No person should be sacrificed as a means for the good of another. This is a moral precept that recognizes the intrinsic worth of every human being." Speaking of human beings, people have survived a diagnosis of brain death. In 2007, Zach Dunlap was a young man who had a severe head injury following a four-wheel ATV accident. He had a bad injury. He had brain tissue coming out of his ear. But because Zach was too unstable for some of the usual brain death tests to be performed, his brain death diagnosis was based on a no-flow brain blood flow scan. Now, the American Academy of Neurology Brain Death Guidelines says that ancillary tests like brain blood flow scans have shortcomings, and none are 100% sensitive or specific for a diagnosis of brain death, meaning there will be false positives and negatives. So Zach was being prepared to have his organs removed, and in fact, the helicopter was landing with the team who was going to harvest his organs when Zach's cousin, a registered nurse from another facility, came and didn't believe that Zach was dead. He took his closed clasp knife and scraped the bottom of Zach's foot, and Zach withdrew his leg. So he called the nurse over, saying, look, my cousin's moving. And the nurse said, well, they teach us in brain death school that they can be moving and still be dead. Those were her exact words. So Zach's cousin went over to his hand and applied a painful stimulus, and Zach pretty much took a swing at him. Well, now the nurse said, now that movement crossed the midline. That's a meaningful movement, and the procedure was called off. Thankfully, Zach made a full recovery. He now has gotten married, he has a little girl, and he works a job. But one of the most horrifying things about this story is that Zach reported later that while laying in a hospital bed, he heard every word as doctors told his parents that he was brain dead and could become an organ donor. And Zach said, there was nothing I could do. I couldn't move or sign or anything. I could just get extremely angry. And this is even more concerning to me as an anesthesiologist because, many anesthesiologists do not give these patients consciousness-blocking drugs, just paralyzing drugs. Can you imagine the horror that Zach would have experienced, unable to move, speak, or sign, taken to the operating room to have his organs removed, possibly without proper anesthesia? Another famous brain death survivor is Jahi McMath. In 2013, Jahi McMath was a little girl with sleep apnea, and she underwent a tonsillectomy and palate repair. Unfortunately, she had severe post-operative bleeding and had a cardiac arrest after the procedure. 3 days later, her parents were told that Jahi was brain dead and could become an organ donor. But when her parents looked at her, she didn't look dead. She was warm, she was moving at times, she looked like all the other little children in the ICU who were getting better. Jahi's parents received help from Dr. Paul Byrne and were able to have her transferred to New Jersey, the only state with a religious exemption to the brain death diagnosis. And there, Jahi received more care and improved. In fact, she began responding first to her mother's voice and then to commands. Jahi was even able to move to her mother's apartment where she got her period. Menstruation is not something seen in corpses. And she began to respond so well to commands that you could ask this little teenage girl, Jahi, which is the FU finger? And she would put up the proper digit. Two neurologists, Dr. Calixto Mercado and Dr. Alan Schumann, evaluated Jahi and found she no longer met the criteria for brain death, but was in a minimally conscious state. Jahi McMath is an important case because she shows that a correctly made, according to the guidelines, diagnosis of brain death is not known to be an irreversible state. Jahi was declared brain dead by 3 doctors. She had 3 failed apnea tests. She had 4 flatline EEGs and a no-flow cerebral perfusion scan. Yet, when she was given further care, she improved to the point of following commands. Jahi McMath shows that a so-called correctly made brain death diagnosis is not death. So how could patients like Zach Dunlap and Jahi McMath be declared brain dead and yet improve? Well, there's a condition described in 1999 by Dr. Cicero Coimbra, a neurologist from Brazil, called global ischemic penumbra, or GIP, that perfectly explains how this is the case. During a brain injury, brain blood flow is decreased. And when brain blood flow decreases below 50% of normal, the brain, like any other organ, shuts down its functions in order to save energy. But actual tissue destruction doesn't occur until brain blood flow decreases below 20% of normal for several hours. So between 20% and 50% of normal blood flow, the brain will be quiet and unresponsive to testing and will fulfill the requirements of the brain death guideline as being brain dead. But with continued efforts to improve cerebral blood flow, recovery is still possible. GIP is like when a power outage happens in your house. Nothing works, but the wiring isn't destroyed. Get that current flowing again, and the lights will come back on. And in the same way, for a proportion of these people, continued efforts to improve cerebral blood flow will let their lights come back on, at least partially. Moreover, the American Academy of Neurology Brain Death Guideline does not fulfill the requirements of the Uniform Determination of Death Act. In 2015, in the case of Aiden Halou, the Nevada Supreme Court ruled unanimously that the AAN guideline did not fulfill the letter of the law. Because of the disconnect between the AAN brain death guideline and the law, an effort was actually made to revise the Uniform Determination of Death Act. The Uniform Law Commission studied the problem for several years, but was unable to come to any consensus and tabled their efforts in 2023. Undeterred, the American Academy of Neurology 3 weeks later came out with a new brain death guideline, essentially recapitulating the proposals refused by the Uniform Law Commission. The 2023 AAN guideline explicitly allows people to be declared brain dead in the presence of ongoing brain function. Did the AAN have any new facts, studies, or data to support this new guideline? If you go to the methods section of their paper, you'll find this. Because of the lack of high-quality evidence on the subject, a novel, evidence-informed, formal consensus process was used. You know, it's troubling that we've been declaring people brain dead for nearly 60 years, and there's still no high-quality evidence for it. In fact, this guideline was made by 3 rounds of anonymous voting. What happened to the scientific method? The 2023 Brain Death Diagnosis Guideline emphasizes that brain death is a bedside diagnosis and that ancillary testing is only needed in cases of doubt or inability to perform components of the bedside exam. It tests for unresponsiveness, but of course, the inability to respond is not the same thing as the loss of inward awareness or consciousness. Zach Dunlap was unable to respond, but he was fully conscious and listening as people were telling his parents that he was brain dead. The guideline says that there should be no motor response to painful stimulus. But again, the guideline says it can sometimes be challenging to determine whether a movement is cerebrally or spinally mediated based solely on clinical examination, as was the case again in Zach Dunlap. The guideline goes on to say if you're not sure if your moving patient is dead or not, the guideline actually says you should ask a colleague. Now, the UDDA says that there should be the irreversible cessation of all functions of the entire brain, but the AAN guideline does not test all functions of the entire brain. They test a handful of brain stem reflexes. And then there's the apnea test, in which the patient is disconnected from the ventilator and observed for breathing. But the guideline states, selection of targets for this challenge is arbitrary because no scientific data demonstrate at what level of carbon dioxide breathing would be stimulated. The National Catholic Bioethics Center considers the new AAN 2023 Brain Death Guideline, and I quote, a decisive breakdown in the public consensus on death and organ donation. People declared dead under the AAN Brain Death Guideline are neither biologically nor legally dead under the UDDA. So what is driving the brain death diagnosis? Organs. Dr. Elko Vidics, a neurocritical care specialist at Mayo Clinic and the author of the 1995, 2010, and 2023 AAN Brain Death Guidelines, stated in 2006, the diagnosis of brain death is driven by whether there is a transplantation program or whether there are transplantation surgeons. I do not think brain death examination now in practice would have much, if any, meaning if it were not for the sake of transplantation. Even utilitarian philosopher Dr. Peter Singer calls brain death an ethical choice masquerading as a medical fact. The emperor brain death has no clothes. In the 1990s, in an effort to expand the donor pool, a new way of becoming an organ donor was discovered. This is called donation after circulatory death, or DCD for short. DCD donors are not brain dead, but they have a poor prognosis and they're either not expected to survive or they have decided that their quality of life is unacceptable. Their death is a planned event coordinated to occur at a specific place and time in order to allow organ procurement. DCD donors are given a do not resuscitate or DNR order because they could be resuscitated, but a decision has been made not to do so. Because of this, they do not meet the letter of the law under the Uniform Determination of Death Act, which stipulates that there must be an irreversible cessation of circulatory and respiratory function for a valid definition of death. Because DCD donors do not meet the UDDA's irreversible standard, doctors use the word permanent to describe their deaths. Permanent is defined to mean that the patient is unlikely to improve on his own, and no efforts will be made to improve or reverse the patient's condition. Now, this is like saying that a drowning man is dead already because no one's going to swim out to save him. On their last day of life, DCD donors are taken to the operating room, removed from their ventilator, drips, or infusions, and observed until their heart stops beating. Then, depending on where they live, there's no universal standard. In my state of Wisconsin, it's 2 minutes. In other states, it's 5 minutes. Doctors have a 2 to 5 minute standoff period to observe for any spontaneous return of circulation. If the heart doesn't start beating within that 2 to 5 minute period, organ procurement begins as quickly as possible because warm organs very quickly begin to deteriorate. But the problem with this is that it's well documented. People are routinely resuscitated after just 2 to 5 minutes of cardiac arrest and make a full recovery. In fact, the first time I gave this talk, a young cardiac nurse in the audience gave her testimony about a patient she had just recently cared for who had had 10 minutes of cardiac arrest, but was able to make a very good recovery with very little neurologic damage. So waiting just 2 to 5 minutes is not long enough. These people could still be resuscitated, and if you could still be resuscitated, you were never dead. Dr. Ari Jaffe, a pediatric neurocritical care specialist from the University of Alberta, has published a series of 12 patients who resuscitated all on their own with no medical intervention whatsoever up to 10 minutes after their cardiac arrest, with some making a full recovery. Donation after circulatory death is banned in many European countries because they realize the ethical problems with declaring someone who could still be resuscitated as being somehow dead. DCD organ donation is banned in Finland, Germany, Bosnia-Herzegovina, Hungary, Lithuania, and Turkey. The New York Times in July of 2025 reported on a very disturbing case of a DCD donor who resuscitated on the operating room table during the removal of her organs. Misty Hawkins was a young woman with cognitive disabilities who choked while eating her lunch and had a hypoxic brain injury. She was very ill, and doctors told her parents that they thought Misty would never wake up, and because of her poor prognosis, they offered her parents the chance to withdraw Misty's care in such a way that she could become a DCD organ donor. Now, Misty's mother didn't want Misty to suffer, and she thought maybe something good could come out of their tragedy, so she signed the consent for Misty to become a DCD organ donor. So Misty was taken to the operating room. She was disconnected from her ventilator and her medications. It took her 103 minutes until her heart stopped. Then doctors observed a 5-minute no-touch period and then immediately began working on removing Misty's organ. But when the surgeons sawed through her breastbone, they found that her heart was beating and that she was breathing once more. The organ procurement was called off. Another doctor was called in to stitch her back up. It's unclear whether she received any anesthesia. And 12 minutes later, her heart stopped beating again. To make matters worse, Misty's parents were never told what happened. An organ procurement coordinator called Misty's mother on the phone and told her it just didn't work out for Misty to become an organ donor. Her parents were not informed until a year later when the New York Times contacted them for comment on this story. As a mother, I can't imagine learning what happened to my daughter in that way. Unfortunately, it gets worse. There's a variation of DCD donation known as NRP, or normothermic regional perfusion. If doctors want to harvest the heart, they begin surgery by clamping off the circulation to the brain, making the patient brain dead on purpose, and then they perform a full resuscitation of the remaining organs such that the heart starts beating again in the patient's own chest. How dead are you if your heart can be started beating in your own chest once again? The protocol for NRP from the University of Nebraska says the initial step for ligation, tying off, of the blood vessels to the head is necessary to ensure that blood flow to the brain does not occur. Of course, if you hadn't performed that step and performed a resuscitation, the patient might wake up. The NRP procedure plays fast and loose with the definitions of death under the UDDA. The procedure begins by declaring death under the first clause, the irreversible cessation of circulatory and respiratory function. Then, doctors clamp off the circulation to the brain, making you brain dead on purpose. So in mid-procedure, they switch to the UDDA's second definition, the irreversible cessation of all functions of the entire brain, including the brainstem. And then they perform a resuscitation of the organs so that the heart starts beating again in the patient's own chest. How irreversible was that first death declaration to begin with? Because of these paradoxes, the American College of Physicians, the world's largest specialty medical organization, in 2021 called for a pause to the NRP procedure, saying its ethical and legal propriety had not been met. Sadly, this call for a pause has been ignored. In July of 2025, the Department of Health and Human Services issued a press release about systemic disregard for the sanctity of life in the organ transplant system. The Secretary of HHS said, "Our findings show that hospitals allowed the organ procurement process to begin when patients showed signs of life, and this is horrifying." They examined 351 cases where donation was authorized but not carried out. They found 103 cases showing concerning features. There were 73 patients with neurological signs incompatible with organ donation, and 28 patients appeared to be alive at the time that organ procurement was initiated. The case that prompted Health and Human Services investigation was the case of T.J. Hoover. In 2021, T.J. Hoover was declared brain dead. But on the way to the operating room to remove his organs, he began looking around and was visibly crying. His family was told that these were reflexes. A whistleblower at the time said, "He was moving around, kind of thrashing, and then when we went over there, you could see he had tears coming down. He was visibly crying." After 2 doctors refused to perform T.J. Hoover's organ harvesting, the organ procurement coordinator reportedly was told to find another doctor. Thankfully, the procedure was called off, and Mr. Hoover was able to recover, so much so that he was able to dance at his sister's wedding a couple of years later. So in summary, I agree with Drs. Verheij, Rady, and McGregor, who wrote in 2009, "Heart-beating or non-heart-beating organ procurement from patients with impaired consciousness is de facto a concealed practice of physician-assisted death, and therefore violates both criminal law and the central tenet of medicine not to harm patients." Brain death is a prognosis of death, not death itself. Taking organs from brain-dead donors is an act of homicide against vulnerable, neurologically disabled people. Human life continues as long as the body-soul unity continues, even with the help of technology. Brain death diagnosis guidelines are unable to predict irreversibility, as was shown by the case of Jahi McMath. DCD and NRP organ donors have their organs removed during a time frame when resuscitation is still possible. And remember, the UDDA definition of death is irreversible. This is clearly not the case for these donors. What really bothers me is that the public is being denied full transparency and truly informed consent when they register to become an organ donor. In fact, contributing to this lack of informed consent, the definitions of brain death and donation after circulatory death on the organdonor.gov website are both incorrect. On the HRSA organdonor.gov website, they say, brain death occurs when the brain is totally and irreversibly non-functional. But the AAN guideline expressly states that brain death may be declared in the presence of ongoing brain function. Jahi McMath and many other brain death survivors show that doctors are unable to predict irreversibility. Brain death has been shown to be reversible and is not true death. Here's the definition of circulatory death from organdonor.gov, which is also incorrect. Circulatory death occurs when a person's heart stops and cannot be resuscitated. Just like brain death, there is no recovery from circulatory death. But DCD donors could be resuscitated, but they have a do not resuscitate order, so they will not be resuscitated. People have self-resuscitated with no medical help at all, up to 10 minutes after cardiac arrest. DCD donors, like Misty Hawkins, have resuscitated themselves on the operating room table. If you could still be resuscitated, you were never dead. An increasing number of voices are being more honest about this. Dr. Franklin Miller and Dr. Robert True wrote in 2012 in their book, Death, Dying, and Organ Transplantation, brain-dead donors remain alive, and donors declared dead according to circulatory respiratory criteria are not known to be dead at the time their organs are procured. That was 2012. Law professor Thaddeus Pope delivered a lecture at Tulane entitled, Dead Donor Rule Violations Are Rampant, and his examples, brain death, DCD, and NRP. Doctors are aware of this, and utilitarian philosopher Dr. Peter Singer wrote, I argue that the evidence now clearly shows that brain death is not equivalent to the death of the human person. Considering everything I've just said, you might be surprised to learn that I am not opposed to transplant. Living donation, in which both the donor and the recipient remain alive after the procedure, is a wonderful and ethical way of helping somebody in need. And tissue donation, things like skin, bone, corneas, heart valves, can be ethically donated from a biologically dead body. More information about the different types of organ donation and which are ethical can be found at my website, respectforhumanlife.com. I know that was a lot, but I don't want you to come away from this feeling hopeless. If you're a medical professional, a doctor, a nurse, it's not possible that you can personally investigate everything that you're taught. The knowledge base that you are responsible for is simply too vast. You were taught that brain death was death, and you had no choice but to accept the idea on authority. If you gave a beloved family member to become an organ donor, you did the best thing you knew to do at the time, out of the kindness of your heart. It is not your fault that you were not given this information. And if you've received an organ, we're glad that you're here. Again, you made the best decision you could with the information you had available at the time. But we have to move forward in honesty, because knowledge is power and things must change. So what does change look like? The public needs full transparency about how death is declared to be able to give fully informed consent before being registered as an organ donor. Because it's well documented that people have self-resuscitated 10 minutes after cardiac arrest with full recovery, DCD donation with a mere 2 to 5 minute waiting period must cease, not to mention NRP. And lastly, we need a nationwide opt-out to the brain death diagnosis for any reason, not just a religious exemption in a single state. Medicine has been here before when we were confronted with evidence that went against standard practice. Most people know that in the past, doctors didn't believe they needed to wash their hands before caring for patients, and that had to change. But what most people don't know is that the doctor who discovered the necessity for hand washing died before the procedure became standard practice. Change takes time, but this has gone on long enough. We have the evidence, and we need to learn from the mistakes of our past.